Started. Welcome everyone to the last geriatric medicine grand rounds of this academic year. It's a celebratory day. It's the last day of fellowship for our 4 geriatric medicine fellows and for the palliative medicine fellows as well. I'm not sure if any of them are on, but if they are, congrats to you as well. So Dr. Sofía Jaramillo is our 4th of 4 fellows to present her geriatric medicine grand rounds. They each pick a topic that's of interest to them and present on it. Go ahead, if you don't mind, Sofía, go ahead and introduce yourself and you can go ahead and get started. And congratulations on it being your very last day of fellowship.
Thank you so much, Dr. Bennett. So I am Sofía Jaramillo. As Dr. Bennett said, I am one of the geriatric fellows. And today I will be talking about sexual health and quality of life in older adults. I hope that this is a dynamic presentation, and please feel free to type in any questions or unmute yourself so you can make this a more productive conversation. So as part of my objectives for this talk are to address sexuality in the care of older adults, discover the facts, myths, and challenges of older adult sexuality, recognize the most common sexual complaints in the clinic, identify the function of sexuality in the achievement of quality of life in older adults, and learn ways to approach the matter in our appointments. For the purposes of this presentation, I have based some of my organization in the talks of Doctors Ong, Rodney, and Fredrickson Golsen, with the respective talks for the Northwestern Geriatrics Workforce Enhancement Center. And I highly recommend all of the talks that are available in their YouTube channel. So, in order for us to have a brief idea of how I structure this conversation, first, I'm going to give you an idea of what sexual health is. Then I'm going to emphasize the importance of sexual health. Then we are going to characterize the older adults that we are currently taking care of. And we will talk about factors that interfere in our older adult sexual health, such as myths, barriers, the clinical concerns that they have. Then we will proceed to talk about sexual health and quality of life. We will approach the new dimensions in sexuality for our older adults. And there's also going to be a space to talk about sexual violence in older adults. And at the end, my aim is that all of us can have a good understanding of how broad this topic is and how we can do a better job as physicians. But to begin with, I would like you to scan this QR code and write down the first word that comes to your mind when you hear sexual health. Also, if you're unable to scan the QR code because you're commuting or wherever, please go to the website of Slido and use the number below so you can participate. I'm gonna give you approximately 1 minute so we can have a space to move on. Thank you, Chris, for sharing the link. Well, the answers will be populated at the end of this conversation so we can have an idea of what was our perspective at the beginning of the talk and then how it evolves. So now I'm going to talk about the definition of sexual health, and as you can see, it is decently lengthy. So sexual health is defined as an approach to sexuality founded in an accurate knowledge, personal awareness, and self-acceptance, where one's behavior, values, and emotions are congruent and integrated with a person's wider personality structure and self-definition. Sexual health involves an ability to be intimate with a partner, to communicate explicitly about sexual needs and desires, to be sexually functional, to have desire, become aroused, and obtain sexual fulfillment, to act intentionally and responsibly, and to set appropriate sexual boundaries. Sexual health has a communal aspect, reflecting not only on self-acceptance and respect, but also respect and appreciation for individual differences and diversity, and a feeling of belonging to and involvement in one's sexual culture or cultures. Sexual health includes a sense of self-esteem, personal attractiveness, and competence, as well as freedom from sexual dysfunction, sexually transmitted diseases, and sexual assault or coercion. So, as you heard in the prior slide, sexual health is a very complex topic, and it involves different topics that are going to get involved in our emotional status, our psyche, our perception of our body and body function, and also how we interact with our environment, and of course, how we perceive others and also our own self-perception. So we need to keep in mind that there's going to be a spectrum in sexuality, and this comes with biologic sex. That is something that we were born with. Then gender identity, that is how we feel inside us. We also develop a gender expression. How is that we portray ourselves to others and to our environment? The gender presentation, how the world sees us, and also sexual orientation, that means what we like. As you can see, this is a pretty diverse representation of our own persona. So as I said at the beginning of this conversation, the sexual lives of older adults are a neglected topic in medical research, public health policy, and health practice. It doesn't get much attention and is linked closely to quality of life, health, and well-being. We have been encultured to believe that sex is not appropriate for older people, and not only sex as intercourse, but any type of sexual relationship or activity. Older people who still enjoy intimacy may hide this fact from fear of appearing to be outside the norm. So to characterize the people that we are seeing as geriatricians these days, we need to consider that these days people who are in their 60s or 70s were born in the 60s, and they are well known as baby boomers. These baby boomers have never been a group to sit passively by and wait for others to take notice, in part because of the huge numbers. They will be the largest cohort of older adults in the US history. And this will have a lot of perspective and impact when I later talk about how they are using different resources to express and participate of their sexuality. And then we need to consider that sexuality is a need. And according to Maslow's hierarchy of needs, the functions of sexuality are going to be related to reproduction, to health, and this need that we have to be loved and to have the perception of belong to something also involves friendship, intimacy, family, and a sense of connection. In terms of research on aging and sexual health, there are several studies. The first one was the mid-US that started back in 1995, and that brings this role of behavioral and psychological traits and well-being that will have a positive or negative impact in or affect our sense of control, our goals and commitments. and also social factors that will be implicated with our well-being. There were 3 cohorts from 1995, 2004, and 2013. The 2004 to 2009 expresses the psychological factors could now be linked to biological assessment. And in 2013, they reported that discrimination received by lesbian, gay, and bisexual men and women has linked to increased inflammation proven by factors such as CRP and interleukin-6, and is associated with chronic illnesses. Then the National Social Life, Health, and Aging Project, which is a longitudinal population-based study that also involves social factors aiming to understand the well-being of older community-dwelling Americans. And this is the first national representative study of the intersection between social and intimate relationships and healthy aging. It has gone through approximately 5 rounds now, but the COVID-19 phase was named after COVID-19. Then we have the National Health and Aging Trends study that started in 2011 and also explores how the well-being of older adults has been affected through a Medicare sample. One of the hallmarks of sexual health and research was the Aging with Pride. And this is a national health, aging, and sexuality and gender study that started in 2019 and went all the way to these days, and examines the lab experiences and related changes in aging, health, and well-being among the midlife of older LGBTQ adults. And the age range goes between 50 to more than 100 years. Finally, and something that I will touch base later on in this presentation, is the National Poll on Healthy Aging that started in 2017, and that is a recurring national representative household survey that gives us a lot of insights about the sexual health of our older adults. So when we talked about sexual health in older adults, as I mentioned before, we need to keep in mind the emotional and cognitive aspects. So we know that our older adults have decreased concerns related to pregnancy due to age and functionality. There's also increased expressiveness, so they have a higher sense of intimacy and connection, and later on we will know these as sexual wisdom. They have certain religious values that are present because of where in time they were born. There is perception of relationship satisfaction later in life because they have built up these relationships for some period of time. Females experience changing in sexual desire. Of course, both sexes experience depression, and both sexes are affected by dementia. Unfortunately, in the dementia population, they seek sexual experiences with other people because they are unable to recognize the long-term partner, and there's also a change in this relationship between lover and now caregiver. In terms of physicality, we see that there's an increase in weight, and that can affect self-image. There's decreased visual acuity, hearing, sensibility in erogenous areas. The musculoskeletal system is also affected by aging, decreasing skin turgor and elasticity, tone, the muscle tone, the flexibility and balance. Women experience dryness in the vaginal area that is shorter, narrower, and lacks lubrication. And approximately 4 in 10 females experience anorgasmia. Males suffer from erectile dysfunction and the so famous dry ejaculation. And there are other conditions that will affect both sexes: atherosclerosis and its consequences such as stroke, CAD, CHF, PAD, COPD, incontinence, and now the rising presence of STDs. And in terms of circumstances, we know that older adults have more time in their hands. They have more privacy. They have some of them have experienced widowhood that makes it more difficult to engage in expressions of sexuality and companionship. There is difficulty meeting people and finding social connectedness. Females have decreased chances to find a partner, and for most of them, priorities change. So it is important to realize that the response in older adults also changes. So what is considered normal of the most frequent presentation of sexual response is related to sexual appetite, sexual consumption and practice, and also sexual society. In order for people to engage in intercourse or any other expression of physical intimacy, there are certain attitudes, fears, expectations that are related to your cognitive sphere and the function of your body connected to the limbic system and the spinal centers. So it is important to realize that is a whole body experience, and because our bodies change as we age, our responses in the excitement, plateau, and orgasm phases also change. Most of us know that males tend to have an excitatory phase, reach orgasm, and then plateau and have this refractory period when they are younger. That gets to be longer and longer as they age. And females can experience the sexual encounter in different ways, in the sense that they can achieve excitement and then there can be some plateau phase, or they can achieve excitement, go to the plateau and reach an orgasm, and then encounter the refractory period, or reach multiple orgasms and then reach the refractory period. Same thing in older females. This is also going to change because refractory period may be longer, and the stimulus necessary to achieve orgasms will require to be higher. But something that it's important to consider as we see this physiology of sexuality is when older adults give up their sexuality, it is primarily due to social and psychological causes rather than biological and physical causes. We can usually be remediated. And another aspect that I wanted to bring to your attention is sexual response and in gender minorities. We know that our gender minorities express more mental distress, and they have decreased openness about gender and sexual identity with providers at facilities due to fear of mistreatment and discrimination. And I will elaborate more on this later on. So now we can confidently say that sexuality has an emotional, physical, and environmental and societal impact. So now it is a good time to kind of rehash on what sexuality changes people experience as we age. So some of the most common myths about sexuality in older adults are that after 50 was a fast trip into a kind of sexual deep sleep. According to Rome, the purpose of sex is to make children. According to Hollywood, sex is only for the young, healthy, and beautiful. And for the medical profession, sex consists only of risks and dysfunctions. And there's also this perception that there's an obligation in older women to engage in sexual activities. Now, what we know as fact is people age 65 to 80, 17% talk to their doctor about sexuality. Only 40% were sexually active. And from that 40%, 73% were satisfied with their sexuality. And in terms of medications and supplement use that has sexual health impact, males were using about 18% of medications that have an impact, and females had a 3% use of medications with side effects in the sexual health realm. 2/3 of older adults were interested in sex, and they realized that sexual manifestations change. As I said before, as our body changes, some of our older adults experience frailty. They may have manifestations such as urinary, fecal, or flatus incontinence. For instance, engaging in intercourse may not be as pleasurable or enjoyable as it used to be in their younger ages, but they find a lot of satisfaction through the act of intimacy, kissing, touching in other erogenous areas. So this is something that we need to acknowledge when they come to our visits. More than 50% of them reported that it is important in their quality of life to have a healthy sexual life. People age more than 60 who have regular intercourse, 74 of them were men and 70% of them are women, and they find their sex lives more satisfying. Many are on a quest to find out what their sexual desires really are and how to safely express them. And they also perceive that there's this obligation and stress in older men to engage in sexual intercourse, although at this period in time, their priorities lean towards intimacy. And as I said before, in terms of changes and concerns, because of after menopause, females experience a decreased production in estrogen. They experience decreased lubrication, and that makes up to 39% of complaints in the clinic. The decrease in testosterone as well in females leads to decreased interest, and this is a concern in 43% of females. They also experience decreased erotic sensitivity in the erogenous areas such as nipples, clitoris, and vulva, and 34% are unable to reach an orgasm. In terms of males, there's also a decrease in testosterone, although it does not involve clinical manifestations and the need to supplement these hormones. However, even minor decreases in testosterone lead to decreased arousal because there are receptors of testosterone in the locus coeruleus, that is the cerebral part that allows us to feel the sensation. There is decrease in sexual interest, there is premature ejaculation and erectile dysfunction. They experience an increased refractory period, and most 37% of them experience some sort of erectile difficulties, such as prolonged erection without ejaculation, decreased seminal fluid volume, and decreased testicular elevation. Any of them can be of concern for our patients. So, as you can see, 76% of older adults between 65 and 80 years old agree that sex is an important part of our romantic relationship. And 54% of those in a romantic relationship reported they are currently sexually active. So there's also a relationship between how they perceive their health and how they engage in sexual activity. So people who consider that they have excellent, very good, or good health, 55% were non-sexually active, but 45% were. And people who consider their health as fair or poor, only 20% were sexually active. From people between 65 and 70, they were 2 times more sexually active than before, and 30% reported interest in sexual activity. From people between 71 and 80 years old, 19% were still interested. In terms of females, 12% were interested, 31% were sexually active, and they reported that they felt more satisfaction than at younger ages. And 69%, they considered that is an important part in the romantic relationship. For males, 50% were interested, 51 were sexually active. And when they reach more than 80 years old, 15 to 25% were still sexually active. And 84% of them reported that it's important in part of the romantic relationship. So the data that I just presented is part of the national poll on healthy aging. And as you can see, one of the biggest questions was, if you were to have a problem with your sexual health, who will you talk to about it? 62% reported that they will talk to their healthcare provider, 36% to the spouse or partner, 70% to no one, and 10% to a family member, friend, or other person. What is concerning is the question is related to have a problem. So it needs to have a trigger to allow these people to talk to somebody about their sexual health, which becomes an issue for reasons that I will explain later on, such as the increased numbers of STIs in the older adult population. Now, what are the barriers that the poll found in terms of older adults engaging in sexual activity? Some of them were lack of a healthy sexual partner, depression, the monotony of a repetitive sexual relationship, a spouse's physical unattractiveness, hormone variability, and illness and or iatrogenic factors. So at this time, we have been very heteronormative about the concerns that older adults that identified as a male or female express. But it is also important as part of a holistic approach to consider that there is a growing LGBTQ community that has a lot of needs in terms of social determinants of health. And why I want to bring this to your attention is because experienced sexuality, as we know, it's not only the perception that we have with our bodies of how we enjoy certain activities with ourselves or with others, but also how we relate to our community. So Dr. Frederiksen Golsen did a lot of research in this regard, and it still does, and has found that LGBTQ people have higher levels of education and they have higher preventative care, such as screening for STDs or HIV or cancer. And they also have higher levels of health coverage. However, they also experience higher levels of poverty, and poverty has also been associated with higher incidence and prevalence of alcohol and tobacco use, sleep disorders, stroke, CAD, asthma, osteoarthritis, higher number of comorbidities, cancer, obesity in gay men, and disability. And this disability is more prevalent in this population since younger ages. There is also higher levels of poverty within the LGBTQ community in the transgender men community. They are more likely to be partnered, but they are less likely to be married. And this has to do with what the culture and the societal perception and policies were back in the day. Lesbian and bisexual women have higher likelihood of employment. Gay and bisexual men have less children in the household, so they tend to feel more loneliness. They also have higher prevalence of risk factors such as lifetime victimization and internalized stigma. And there are some protective factors such as the LGBTQ community has bigger network size. So in terms of challenges, research has shown that there is a cultural and societal views and beliefs towards sexual health that stigmatize the sexuality in older adults. Stigma, embarrassment, and discrimination play a huge role on this. There's lack of education and training of healthcare providers, and there is ageism because we don't want to think about our parents or grandparents having sex. There's also quality of relationship between patients and health professionals that has different levels. For example, PCPs assume that 60+ people are not sexually active. PCPs are not willing to discuss sex. PCPs expect patients to bring up the subject. Patients expect clinicians to bring up sexual concerns. And there is this unfortunate myth about STIs are not present in the older adult age group. So now a word about sexual transmitted diseases. The reason why they are becoming more prevalent in older adults is the widespread use of online dating, and this has been conceived as an incubator for STIs because it increases the number of sexual meetings that are possible for our older adults. And I will talk about online and internet use amongst older adults. Approximately 46% increase in STIs over the last 5 years is due to lack of sex education and sexual health literacy. And the biggest topics that are unknown for our older adults are the impact of ongoing sexual engagement on health and well-being, pleasure, the use and benefits of lubrication, addressing dysfunction, sexual aids, and masturbation, and consent. Our older adults also believe that they are not at risk of contracting STIs, although bodily changes associated with aging can make transmission more likely to occur, such as the lack of lubrication and the presence of microtears during sexual intercourse. For example, males think condoms diminish sexual interest or pleasure, and females have lower condom use because they are no longer thinking or concerned about becoming pregnant. Females also have limited experience of negotiating with new partners about their sexual desires and practices, including the use of condoms and lubrication. So as we see, the fact is that sexual activity, interest in sex, and satisfaction with sex life are major drivers of sexual health conversations between patients and healthcare providers. Unfortunately, this happens only in 39.5% of visits. And a number that is highly concerning is 15.8% of older adults are not very or not at all concerned about STIs in their age group, even if they are practicing or engaging in sex or intercourse. So what are the actionable areas for us as physicians and healthcare providers? First, increase the visibility and importance of older adult sexuality in a non-stigmatized way. Then increase the knowledge of medical students and physicians and provide accurate, up-to-date knowledge to older adults. And display more openness to discussing elder sexuality in clinical encounters by creating an accepting atmosphere. And more tips on that by the end of the presentation. Also, it is important to realize that sexual identity plays a huge role in the older adult sexuality because the years that they have been hiding their true identity equal to a lot of stress and fear. So I found this article about the variation in subjective aging by sexual minority status, and this was the examination of 4 perspectives. And what was found is that holding an older or less youthful identity is associated with being younger, male, and white, and having lower perceived financial well-being, worse self-related health, and more chronic conditions. So that is why I make pause and put a little bit of emphasis about the social determinants of health of our LGBTQ population. This study was conducted with the mid-US dataset that it involves people aged 25 to 74. It involves screening through telephone and a mail questionnaire. The response rate for both was 61%. And they focus on three areas: the age-related self-perceptions, the generalized views on aging, and the aging bodies. The results for age-related self-perceptions reveal that sexual minority women, they report on average younger desired ages than do heterosexual women. They have similar results for generalized views on aging, but sexual minority women view the life course as more compressed. Lesbian and bisexual women report younger ages when they start the middle age and when they finish middle age. Women's views of aging bodies also differ by sexual minority status, with lesbian and bisexual women reporting more favorable 10-year predictions of their sexual lives. However, the difference approach significance for males because they perceive middle age to start at a later age, and these forecast a less favorable health in 10 years' time. So now I want to bring your attention to something that is really important. We are talking about quality of life, and quality of life is an abstract concept. And the aims of describing quality of life is to capture the well-being, whether it's an individual, or a population at different points in time. And it also has to be related with multiple aspects of our lives, either personal health, relationships, education, work environment, social status, wealth, security, safety, freedom, autonomy in decision-making, social belonging, or our physical surroundings. So as you can see, it is an abstract concept and can have different implications for different people. So it is hard to standardize what the value is because it's a qualitative assessment. However, in sexual health, it's being what has happened is the development of a sexual quality of life assessment. And we have the sexual quality of life questionnaire for males and for females. And I stumbled upon this article related to sexual quality of life and aging, and this was a prospective study of a nationally representative sample. And the whole purpose was to describe whether the sexual quality of life has a relationship with age. And older adult sexual quality of life was differentially influenced by the quality and not the quantity of sex. And aging may have been associated with the acquisition of skills and strategies that can buffer the age-related declines in sexual quality of life. Because what was found is aging negatively impacts the sexual quality of lives of females regardless of age compared to males. And the time in history plays a role, but this was related to cultural and societal modeling. The race, sexual minority status, education, marital status, having children, and religiosity also plays a huge role in the differences in sexual pleasure, satisfaction, and sexual quality of life. The sociocultural influences on sexuality are important to consider in research with a focus on the effects of aging. So with age, there was a decline in the sexual quality of life across all age groups, more marked in females. Then there were 4 factors that were perceived to be predictors of sexual quality of life. Those are perceived control over sexual aspects of life, the amount of thought and effort that we put in the sexual aspects of life, the frequency of sex, and the number of sexual partners. However, as the sample population aged, the perceived control and frequency of sex became less strongly associated with sexual quality of life of older adults. But the thought and effort invested in the sexual aspects of life became more strongly associated with the sexual quality of life, marking the fact that the physical act of intimacy and contact was not as important as the psychic perception and thought of being involved in a relationship and having this emotional intimacy. And as I mentioned before, because older adults have had more experience, more time to know themselves, know others, and they know how they better interact in society, they develop what is called sexual wisdom. Then there's this article about sexual function positively correlated with older adult sexuality and quality of life. This is a Brazilian article. They studied 231 male older adults, only male. And they found that the sexual function was positively correlated with sexuality in a moderate magnitude and with quality of life in a low magnitude. But what was very highly correlated was self-confidence as the highest positive correlation with quality of life. Then I found this systematic review about sexual health and subjective well-being in older age groups. And throughout different data sets, they found out that living a fulfilling sexual life is an essential part of this subjective well-being that we define as quality of life. So we have been talking a lot about how experience sexuality either at a personal level of experience or having different sexual practices with others or with the environment affects our perception and our well-being. And something that is important in older adults is the internet. The internet has provided older adults one of the fastest growing groups of internet surfers of approximately 8.3 hours per week, a venue for expressing, experimenting, and challenging the popular idea that they are asexual, uninterested, or incapable of being sexual, because this is a non-discriminatory environment. It is accessible, affordable, and anonymous. So the uses that our older adults are given to the internet are dating through chat rooms, this companionship through advertisements, courtship. They also are trying to get aware of their bodies and how they experience sexuality through sex education. But there's also a high presence of erotica, pornography, paraphernalia, and cybersex. And as I mentioned before, the widespread use of the internet has led to an increase in STIs. Finally, a word about sexual violence. According to the WHO, sexual violence is every sexual act directed against a person's will by any person, regardless of their relationship to the victim in any setting. Worldwide, according to a European study, approximately 0.9% of older adults were sexually victimized in the past year. In community dwelling older adults, the last year prevalence of sexual violence can vary between 0 to 3.1%. 30% of sexual violence was perpetrated by friends, acquaintances, and neighbors, 27% by others, 24% by partners, 3% by offspring, and 3% by other relatives. So this is important to keep in mind when we see people, older adults in our clinic that have any signs or symptoms of violence and exploring sexual violence, because violence, it is not only limited. Sometimes we believe that it's only psychological violence or physical violence, but it can also involve sexual violence, and more so in our vulnerable age group. I also wanted to bring your attention to how about the long-term care facilities and people living with dementia? Are they able to experience sexuality? And the answer is yes. According to the capabilities approach, part of one of the spheres is bodily integrity. And romances between residents are therefore favorable if there are no signs of abuse whatsoever. And they are self-evidently residents can express their sexuality and gender identity with their clothing. I also want to bring to your attention the exercise of sexuality in older adults, and more so in older adults that suffer from disability. And this is a very important article by Dr. Jecker that is part of the ethics group in our university. And she approaches this controversial topic in the sense that while there are age-related changes and chronic disease can be disruptive to sexual activity, they do not eliminate older adult sexual feelings or preclude engaging in sexual activities with assistance. And that is the reason why affording older people access to sex robots as part of a reasonable effort to support their central human capabilities can lead to a more positive experience in this age and also vulnerable population. Now, we have been talking a lot about sexual health and how it's expressed, how it affects our psyche, how we can ask questions in the clinic, what are going to be a lot of concerns in this age group, how to de-stigmatize sexuality in populations such as the LGBTQ community, people living with dementia, or people living in long-term care facilities. And what I found that it's the most important thing is ask our patients what matters the most to them. And it was interesting going through this research that there was this report of one man in his 70s remarking that being sexual in later life was as important as eating, and it's to be encouraged. So using the patient priorities care approach, we know that people in older age want to connect. So saying something such as sexuality is part of your health without a partner, so some people find themselves sexually isolated. Would you like to address this? Other people would like to enjoy life. So saying something on the lines of continuing intimacy is healthy. Do you mind if we talk about it? Other people would like to manage their health. So normalizing. This medication change aspect of your sexuality is so, does this bother you? Other people would like to function. Saying something such as, some people find challenging to adapt to new levels of mobility, which in turn can affect other areas in your life, such as your sexuality. Would you like to address this? Remember, in words of Dr. Frederickson Goldsand, invisibility creates vulnerability and tends to lead to very poor healthcare outcomes. And there, I also want to share with you some screening tools that are important to talk about sexual health in older adults. Some of the studies, more so in Australia and in the European countries, have found that a good way of starting the conversation about sexual health is to ask the patients to privately fill a questionnaire while they are waiting in the waiting area to come to the PCP's appointment, because it decreases the chances of them being put on the spot. Most of them come to our clinic accompanied by children or other caregivers, which can make the situation very stressful and decrease the privacy that this subject needs to have. So there is this personal assessment of intimacy in relationships. There is a sexual health inventory for men, and there is the PLICIT model. The PLICIT model is a very interesting concept where the physician will ask what is the main concern of the patient, give focused information about what are the most concerning factors about it, and then develop a plan of action so in conjunction with the patient. So to talk about sexuality in our times, it is important to realize that we as geriatricians sometimes fulfill the role of being PCPs. So things that we can do to enhance the sexual experience of our older adults are to screen for major depression or generalized anxiety disorders that can affect their performance and their interactions, medical and functional optimization, medication review and the prescription, because some of these medication can impact how they are able to perform these encounters. It is also very important to enhance the sensorial experience, and we can count on dermatologists, audiologists, and ophthalmologists. Don't forget, the skin is the largest erogenous area in our bodies. Then there's the functional optimization. For people who struggle with incontinence, we can lean on urologists, GI doctors, and even a surgeon. For organic issues, more so in females, it is important to ask the opinion of a gynecologist. And for people who have any kind of mobility issues, limitations, or disability, we can use our friends in physical medicine and rehabilitation, physical and occupational health. And it's also important to help the minds and the social environments and health and well-being of our older adults through our psychologists. Some of them have certification in sexology, social workers, and case managers. So as you can see, it takes a village to enhance the experience of our older adults. Finally, I want to leave you with this phrase. Sexual wellness is part of the tapestry of mental health and confers psychological, cognitive, and physical benefits throughout older age. However, wellness is unattainable without first granting sexual rights that are integral to being a sexual citizen in this culture, defined as the control over one's body, feelings, relationships, access to representation, relationships, public and socially grounded choices. And here is the QR code for you to please help me with the evaluation of this presentation. I am open to questions, comments, either through the chat or to people who want to interact.
Thanks so much, Sophia, for that great presentation. If anyone has questions, feel free to unmute. There is a comment from Kay Ritchie. She commented that you did some nice framing to your questions under value domains when you were talking about patient priorities. So
Thank you.
Excellent work on that. But feel free to unmute for questions, or if you cannot unmute, you can type them in the chat.
I have a question, Sophia. Do we have any data on whether a question about sexual health and where your patient is at is low yield if you do it on the intake visit? The reason I ask is we put it into the senior care clinic intake visit, and I'm just wondering if that's a low yield idea until there's an element of trust or communication with the provider. Just wondering if you saw anything on that, like how often they either defer or say it's not important until they get more comfortable.
I did not stumble upon like that specific question. My best guess is what you already are implying in your question. This is an important topic, but when we are starting to build up a relationship with a physician, it may not be the best place to start the conversation, because across multiple papers, what older adults want is to establish rapport and confidence with the physician to later on be able to trust them with this very valuable and sensitive information. And then I was trying to share what the answers were for sexual health. So people believe that it's upward, community, intimacy, shame, condom, sex, it's taboo, holistic, personhood, varies. Isn't addressed, seldom discussed, and individualized. Very good.
There's a question from Dr. Phelan. She's asking if there's a definition of sexual violence.
Yeah, so the WHO defines sexual violence as any sexual, okay, let me see. It's every sexual act directed against a person's will by any person, regardless of their relationship to the victim in any setting. And I will add to that, that is a definition by the WHO, but I will add that there is no consent. And then Tiffany was asking if how often I ask about sexual health in my visits. I have to acknowledge that I have not been very proactive about asking this question to my patients. And that is why this presentation took place, because it is kind of an old excuse, but sometimes we get tangled in a lot of kind of common medicine questions or concerns to our patients. And sometimes in these questions about what matters the most to you, we forget to say, well, sexuality is also part of life. Are you experiencing sexuality? Is there something that you want to talk to me about? Oh, and then Dr. Fallon says that bereavement didn't emerge as a barrier to being sexually active. I briefly touched on that through widowhood, and there's an article that states that females, once they experience widowhood, find more difficult to find a partner and to create this kind of emotional intimacy connection with other people, whereas men are sometimes faster and more easily able to move on. Thank you, Terry. And then Barbara, any data as to how much antidepressants adversely affect sexual desire? Yes, that is one of the things that you may find in Dr. Ong's presentation. Yes, definitively antidepressants will certainly decrease sexual desire. And that is something that that is one of the reasons why when we go through the medication list, that could be kind of the link between this antidepressant is creating a side effect. Is this a good time to talk about the prescribing this medication or trying to lowering the dose and see how you do? So that brings to mind, like, some of these older adults have been on antidepressants. I had a patient who was on antidepressants for 30 years. So that targets multiple aspects of our functions as geriatricians. How should we approach making the culture of long-term care settings more supportive of sexual health for residents? There's an article that says that residents of long-term care facilities have a harder time expressing their sexuality because of fear of judgment and also lack of privacy. So I think that it goes back to education towards the staff that works in the facility, normalization of expression of sexuality, and one aspect of that was touched on the presentation. Even dressing, allowing patients to dress like they want, having that perception that they are still a very valuable contributing a member of society, allows them to have that sense of connection. Also from Barbara, is lubrication for women the first suggestion for increasing desire, or if not, what is? This is a good question. Lubrication is a specific target for when the patient complains about pain during penetrative sex, principally. But I think that the lack of desire, it is something that is it is not that targeted through a physical intervention, but more through cognitive behavioral therapy. Because something that we said is females, as they age, they are more okay with the lack of this physical relationship, with the lack of intercourse, because they found more satisfaction in the emotional intimacy, in the fact that they are they have a supportive partner who's there to listen to them, and that have that kind of mental bond rather than a physical bond. And then Dr. Fellan, antidepressants affect sexual performance, also really important to consider, as many older adults are not SSRIs. Yes, that's correct.
Great. Well, thanks for answering all of those questions and doing it so well. You really took a deep dive into the literature on this topic, and I appreciate you sharing it with all of us. If you don't mind taking down your presentation, I just want to take this last opportunity to congratulate all of the graduating fellows. If you can put your camera on, that's awesome. But if not, it's been such a wonderful year with all of you, and we're so appreciative of the time that you shared with us and doing your fellowship with us at the University of Washington, and you'll always have a home here with us in geriatrics, and we wish you all the best of luck, and we're going to miss you. So feel free to chat in your congratulations or use a reaction in Zoom, but thanks to all of you and congratulations.
And I just want to say, Sophia knows that she got the Abras Award for next year, so she will have a little bit of money to support her education and research. So congrats to Sophia on that.
Congratulations, Sophia. You're muted if you're trying to say something.
Oh, I was saying thank you so much to everybody. It's been a lot of work for this upcoming year. I acknowledge the hard work of Dr. Garcia, Dr. Reed, Dr. Bennett, Dr. Banks. Like, I cannot name every single person who's been rooting for me, and this means a lot. And I hope to work hard to achieve good results for this upcoming year.
You're going to. Do you want to tell everyone what you're doing this next year?
Yes, I'm doing research at the VA with Dr. Garcia, focused on older adults who suffer from low testosterone levels, and hopefully launch my research career in frailty.
Congratulations, Sophia. We're very excited for you and glad you're sticking around. Well, congratulations, everyone. Happy graduation day to the fellows. We're really going to miss you. And have a good, safe holiday weekend, everyone.
I had a wonderful year. Thank you, guys.